Okay, hello everybody. We're gonna talk about asthma and its management. My name is Abdulaziz Al-Yami. I'm a respiratory therapist in Johns Hopkins Hospital in Dhahran. The objectives that I'm gonna go over are definition of asthma, the epidemiology of asthma, risk factors, physiological airway, the pathophysiology of the asthma itself, diagnosis, and the managing of asthma. First of all, we're going to go over asthma definitions, and we're going to go over it in detail because it's very, very important. So asthma is a chronic respiratory disease characterized by periodic attacks of impaired breathing due to inflammation, narrowing, and irritation of the airway. So first, it is a chronic disease, so it's not a one onset disease. It's a chronic disease. It might stay with a patient for many years. And it's characterized by periodic attacks. So that means it's not a constant or persistent sign and symptoms. So the sign and symptoms of this disease, it might come and it might fade out. So what are the symptoms of asthma? Symptoms include wheezing, which is the most common symptoms, coughing, and chest tightness with severe asthma attacks. And as you know that there is no cure for asthma, but asthma can be treated and prevented by some medication or some management. The epidemiology of asthma, based on World Health Organization, globally, more than 300 million people have asthma. And asthma is responsible for one of 250 deaths in the world. So it's something significant. Most asthma-related deaths occur in low and lower middle-income countries. So it's more the prevalence of asthma. It's more common in countries with low income, poor countries. And according to prevalence of asthma in Saudi Arabia, in 2016, the prevalence of asthma in Kingdom ranges between 15 to 25, and that depends on the regions. And asthma has associated with smoking, obesity, and if the patient is a passive smoker, that means he has a history of smoking. And those who has higher education, they have a less incidence to have asthma disease. So what are the risk factors causes asthma? We have two categories for risk factors, host and causal factors. Host factors include genetic susceptibility and atopy. The atopy, that means this patient has an immunity disease that advances or improves the inflammatory disease, including asthma. And we have causal factors, including indoor allergens or outdoor allergens, for example, pollens or fungi, active and passive smoking, respiratory infections, diet and drugs, obesity, socioeconomic status, occupational exposure, and chemicals. So all of these are factors associated with asthma. So if you want to go and look at the airways itself. So the airway, this is a normal airway. We call it physiological airway. That's a normal patent airway. Look at how it looks like. So from the outside diameters, there is no tighten from the muscles because there is a muscle around the airways. So this muscle should be smooth, relaxed, not in tightness. And from the inside, you're gonna find that the airway is clear and pinkish, and there is no any swelling inside the airway. So all of these, if there is a swelling or if there is tightness in the airways, those are signs and symptoms of asthma. And if there is no, the normal picture of the airway has no overproduction of sputum or a mucus. So if there's overproduction of sputums, that could be a sign of airway disease. One of them is asthma. So if you want to compare the normal airway with non-normal airways, this is an airway for patient who has asthma. You're going to find that this airway is inflamed. So one of the changes that happen in the airway is inflammation. So you're going to see there is an inflammation inside the airway. Number two, there is a bronchoconstrictions, because as you know that asthma, the airways has a muscle. And one of the signs of asthma is bronchoconstriction. So those muscles around the airways got tightened and causes bronchoconstrictions. The number 3 of the changes that happen to asthma patients if they have attack is mucus secretion increase. So increase the productivity of sputums. So all of these factors, which is inflammation in the airways, tightness in the airways, and increase the production of mucus, could cause asthma attack, or could cause a reduction of the air movement to and from the lungs. So pathophysiology of asthma includes asthma attack. There is a bronchial edema, which causes a narrowing in the airway. There is also bronchospasm and wheezing. So bronchospasm due to the muscles that are around the airways got tightened and causes wheezing. Increase in the mucus production. This mucus production might cause a blockage to the airway, which goes us to the next one, which is mucus blockage. And if there is a mucus blockage, that means this air, that during breathing, the air goes in and the air cannot go out due to this blockage, which cause ultimately air trapping and lung hyperinflation. And this could happen if the patient is severe asthma attack. So how can we diagnose asthma? We have 5 elements to diagnose asthma. First of all, personal and medical history. So it's very, very important to go over and skim inside the patient's history to find out if the patient has history of asthma among his siblings or family. Number 2 is physical examination. So we have to examine the patient to find out what kind of disease he has, and if the patient reveals the signs and symptoms of asthma. Chest X-ray, arterial blood gas, and sputum cultures. Those can be used as a diagnostic test to diagnose asthma. Pulmonary function test, which is one of the most important tests that can be used to diagnose asthma. Trigger test. Also, this is one of the tests that we can use if the patient has subclinical asthma, and we're going to go over it later. So first, personal and medical history. We have to ask the patient if he has any history of asthma between the family. So, and we have also to evaluate the patient's past medical history, if the patient has any events of bronchoconstrictions in the past. So we have to check patient medical history, if he has any history of asthma episode before, or if the patient using some medication that causes bronchoconstrictions or causes signs and symptoms similar to asthma, for example, beta blockers or aspirin. Again, we have to ask the patient, we have to figure out the patient family history about asthma, if the patient has a history of asthma among his siblings, parents, or others. Social history is very important, especially, particularly if the patient, you have to ask the patient about his occupation. Where does he work? Why? Because some of the occupation, they got exposed to famous molds and chemicals. So all of these are triggers of asthma. House, if the patient lives nearby factories, or if the patient has pets, dots, or carpet inside his house, because all of these are triggers of asthma. Smoking, either if the patient is a smoker or one of his family is smoking, which we call it passive smoker. So all of this can give us an idea about the patient history and what triggers the patient to have an asthma. Physical examination, by inspecting the patient. We have to look at the patient. For example, the patient has asthma attack, this patient comes to emergency department. First of all, we have to look at the patient, inspect your patient. And we're going to find that this patient has labored breathing, and this patient is in distress. So physical examination includes inspection, by looking at the patient by the naked eyes, auscultation, chest X-ray, blood work, CBC or differential, ABG, which is arterial blood gas, and sputum cultures. So all of these are called physical examination. Inspection. So once you have a patient in the port and this patient has an asthma attack, you're gonna find this patient is tachypneic, tachycardic, and you're gonna find that this patient is struggling to catch a breath, which we call to increase work of breathing. Cyanosis, and this is a life-threatening sign. If the patient is cyanosed, that means this patient has a significant deficiency of oxygen in his blood. And this patient, he needs supplement oxygen to improve his condition. Cough or increase AB diameter. Increase AB diameters that could happen as a result of a frequent asthma attack, and ultimately this patient will have an increased AB diameter in the dimension of the chest comparing with the transfer diameter. Auscultation, which is listening to the chest sound, we're going to find most likely one of the most common sign of asthma is wheezing due to bronchoconstriction. So wheezing could be there if the patient has asthma, and if the patient is in severe asthma attack, you might listen to diminished breath sound or absence breath sound. That means the air is not moving because there is a significant obstructions in the airway. So wheezing, it's a sign of asthma, but if the patient is an asthma attack, and we know this patient has a history of asthma attack, and once we listen to his chest, we found that this patient has diminished breath sound or absence of breath sound, that means this patient really he is in very bad condition, and we need to intervene with this patient. Chest X-ray, most of the time, chest X-ray are normal for any patient with asthma attack. So if the patient comes to you and he has an asthma, you do X-ray, most of the time it's going to be normal. In case this patient has severe asthma attack, you might find hyperinflation in the lung, in the chest X-ray. So if the patient has severe asthma, for example, status asthmaticus, that's mean, and this could be reflected in the X-ray, and you're going to find there is a hyperinflation and the flattening of the diaphragm. Pulmonary function test, and this is a test that we do to evaluate the patient's lung flow, breathing flow, and lung volumes. So if the patient has an asthma and we do pulmonary function test to him, we're going to find a reduction or a significant reduction in the lung flow, and also there is a significant increasement in the patient's lung volumes due to air trapping in the lungs. Also, one of the tests that we can use to evaluate the patient's airway hyperreactivity is exhaling nitric oxide. So if the patient has airway hyperreactivity, his airway will produce nitric oxide. And this nitric oxide, we're going to measure it, and from the result, we can tell this patient he has asthma or not. So how we can do it? We're going to ask the patient to exhale for at least 10 seconds directly in this device. Then we're going to measure his exhaled nitric oxide. If the nitric oxide in the exhalation volume is greater than 35 parts per million, that's a positive sign this child has an asthma. So if it is greater than 35 among child, this is a positive test that this patient has an inflamed airway, or he has hyperactivity airway, which equals asthma. But if the client is adult, the result has to be greater than 50 parts per million, so we can tell this patient he has a positive asthma disease or a positive result. So triggers test. Sometimes that patients comes to the clinic and complains that I do have, for example, chest tightness, especially when I work or when I do some exercises. I'll feel chest pains. And when we do this assessment that I have covered in the last minutes, all the tests will be negative. So there is a contradiction between the patients, what he is saying, and comparing to the results that we are comparing to the tests that we have done to the patient. But this asthma can be triggered. So we're going to do a test to the patient, and if the patient has hyperreactivity in his airway, the patient will reflect a bronchospasm. So we're going to give the patient kind of nebulizer and let the patient to breathe from this nebulizer. If the patient has asthma, he's going to develop asthma attack once we are giving him this nebulizer. But if the patient does not have an asthma and we are giving him this nebulizer, he will not show any sign and symptoms of asthma. This is what we call trigger test. So we are triggering his asthma to reveal and to appear his sign, its sign and symptoms. The tests are metacholine challenge tests, and sometimes we ask the patient to do exercises, which we call it exercise-induced asthma. So metacholine challenge test, This is a test. We give the patient nebulizer that causes bronchospasm, and it will be positive if the patient is asthma, and it will be negative if the patient does not have asthma. And sometimes we ask the patient to do exercise, and then we measure his lung functions. If there is a significant reduction in his lung functions, that's mean this patient has exercise-induced asthma or exercise-induced bronchospasm. Exercise-induced asthma or exercise-induced bronchospasm, 90% of asthmatic patients will develop asthma during exercise. If the patient is a known case of asthma and during exercise, this patient will show signs and symptoms of asthma attack, which is commonly. And how we can tell if the patient has asthma during exercise? If the patient's breathing flow falls by 15% from his baseline. So we ask the patient to breathe, and we measure his peak expiratory flow rate at rest. Then we ask the patient to exercise. Then we measure it after exercise. If the result of the peak expiratory flow rate falls by 15% and above, that means this patient has exercise-induced asthma or exercise-induced bronchospasm. Asthma monitoring at home. So can we monitor asthma at home? Yes. By using a device which I mentioned now, which we call peak expiratory flow device. So this is device measures the fastest flow that the patient can exhale forcefully. So as you can see in the picture, this is a typical device, and it has 3 zones. So first, we're gonna give the patient a device. If the patient, during the rest and the patient has no any sign and symptoms of asthma, we're gonna give the patient the device. Then we're gonna ask him to exhale, to take a deep breath. Then we're gonna ask the patient to exhale forcefully in this device to measure his maximum flow that he can do during expiration. And this is gonna be the optimal flow. This is that we're gonna compare the result in the future with this performance. So first we have to take a baseline, and this baseline of this patient has to be normal, no sign and symptoms of asthma. So the patient should not have any asthma attack while we are doing his baseline number. Then we're gonna give the patient this device. We're gonna divide it 3 zones: green zone, yellow zone, then red zone. Then we're gonna give it to the patient to go home. We're gonna ask the patient once every now and then, you're gonna measure your peak expiratory flow rate. So if the result of your peak expiratory flow rate falls in the green zone, that's mean you are controlling your asthma. That's mean you are controlling your asthma. Keep doing with your medication, you are doing fine. But if the patient does his peak flow at home and the result or the indicators here falls, the indicators falls in the yellow zone, which is 52 and 79% from his baseline, that means this patient has impending sign and symptoms of asthma. So he has to use his medication frequently, and he has to double his dose to prevent asthma or to get rid of his sign and symptoms of asthma. How about if the patient does peak flow expiratory device and he exhales in this device and the result or the indicator falls in the red zone? So that's means this patient, he has now severe asthma attack, and he has to seek for emergency help, and or he has to go to emergency department to give him the appropriate or the optimal treatment. So from home, the patient can monitor himself by doing this exercise or by doing this test. Take a deep breath, exhale forcefully. If your result falls in the green zone, that means you are doing well. Continue with your treatment. If the indicator falls in the yellow zone, that means you have, we call it mild to moderate sign and symptoms of asthma. You need to double your dose and take your respiratory medications. And if the indicator falls in the red zone, that means you are in very dangerous shape. You have to go for emergency department for further management. Status asthmaticus. Status asthmaticus is an acute exacerbation of asthma that does not respond to the standard treatment of bronchodilators and steroids. So basically, status asthmaticus, it's a shape of asthma in which the patient has signs and symptoms of asthma, but the patient does not responding to our treatment. Whenever we give the patient bronchodilators to open up his airway, he is not responding. somehow he gets deteriorating. So with this kind of patient, what are the symptoms, and how we can tell that this patient now is in status asthmaticus if he shows this sign and symptoms, including chest tightness, that means there is no air movement, or there is a slightly air movement in and out patient's lung because the airway is totally tightened. Rapidly progressive dyspnea, that means this patient is in dyspneic, he cannot catch his breath. Dry cough or constant dry cough, using of his accessory muscle, labored breathing, then this is a sign of increased work for breathing. Extreme wheezing or silent chest. So if the patient is in extreme wheezing, that means most of his airways are tight and there is no sufficient air movement to the patient's lung. Or if the patient has silent chest, that means this patient has no air movement at all and he's suffocating. He needs a further management. What are the complications of status asthmaticus cannot be treated? So the complication, cardiac arrest or respiratory arrest. So this patient, he might have, his heart might stop beating and we need to do CPR for him to resuscitate him if status asthmaticus did not get improved. So if the patient, now we know this patient is not responding to bronchodilators and steroids, what we have to do? Should we keep him around? No. We have to advance an airway, so we are going to put a tube in his throat where we can mechanically ventilate the patient and sedate him. So we're going to give the patient sedation. He's going to be totally sedated. Then we're going to give him a mechanical ventilation that helps him to maintain his oxygenation ventilation status. Managing asthma, how asthma can be managed? By making medical visits more productive, create an asthma management plan, understand medication and reduce triggers, and the end is learning asthma self-management skills. We're going to go over it after a couple of minutes. So now we're going to go over asthma medications. It's very, very important for asthma patient to know his medication, what kind of medication he uses, and what is the appropriate way to use the medication, because sometimes the patient has his medication at home, but he's not using the medication properly, or he's not using the appropriate medication in appropriate time. So patient should be aware about his medication. So we have a Roscor, which we call short-acting medication. This medication has immediate reverse bronchospasm. So if the patient now, he is in asthma attack, he has to use either albuterol or epidemiology bromide, which we call atropines. So those two medication they have an immediate adverse reverse effect on asthma. So if the patient is asthmatic and he has signs and symptoms of asthma, if he uses albuterol on the epidemiology bromide, his airway will open, then the patient will relieve his airway so he can breathe easily and the signs and symptoms will get away. So those are risk scores. So risk score should be used only if the patient in asthma attack. But if the patient is not an asthma attack, as I mentioned in the beginning of the lecture, this disease is a chronic disease. So it has to be controlled. We have to prevent the patient from having any asthma attack. He is an asthma patient, but we don't have any attack happens to him. So we have to control his airway by giving him some medication. One of them is steroids. Those medication will prevent any further or future asthma attack. For example, formoterol, which is help to improve lung function or patency of the airways for a long time, salmeterol and fluticasone. So all of these medications can be used to prevent any symptoms of asthma. So if the patient stop using those kind of medication, which are the controllers, he's gonna have asthma attack. Then he's gonna go up and use his risk score medication, which is a short-acting medication. How we can manage asthma, as you can see in this pyramid, if you go from down to up, learning asthma, self-management skills. So we have to know about your disease, signs, and symptoms. Any patient has to know about his disease, especially if the patient is asthmatic patients. Reduce triggers. So one of the treatment of asthma is prevention. So if you know that this things triggers you and it causes you having asthma, try to avoid it. So whenever you're going to avoid it, you will not have an asthma for sure. So for example, if the patient has pits, and you know that pits causes asthma attack for him, so try not to have any pits at home, or try to get rid of your pits. So by prevention, you will not have an asthma attack. And you have to know, as an asthma patient, you have to know what triggers you. For example, if there is a dust, for example, today, if there is a dust, so dust sometimes triggers asthma. Try to use your mask, or try to stay home, not to go outside. So number 2 is reducing your triggers. Whenever you reduce as much as you reduce your triggers, as less as you're gonna have asthma attack. Understand medication. You have to know about your medication, what kind of medication you have to use, how often, and what is the appropriate way in using what is the appropriate way of using your medication. Create your asthma management plan. How come? By using the peak expiratory flow rate. So if you have the peak expiratory flow rate at home, and you're gonna plow in it, and from the result you can tell in which area you are in green or yellow or red, and in which area what you have to do. So for example, if you are in green, that's mean you're doing well. If you are in yellow, that's mean you have signs and symptoms of asthma. You need to double your dose, or you need to consult your doctor. But if you are in a red zone, you have to seek for help, and you have to go to emergency department rushly. Also, you need to make medical visit more productive. You need to go to your doctor periodically, especially your pulmonary doctor, to evaluate your lung function and to evaluate your asthma, to keep everything under control. So asthma, it's a disease, but once you control it, you can live normally, and you can live. Sometimes you forget that you have an asthma if you control it very well. But if you cannot control it and you still negligent, and you don't show very, you have to make it like very significant things, you're gonna have a lot of episode of asthma attack, and a lot of or many visits to the emergency department. Create an asthma management plan. This is a template of asthma action plan. As you can see, there is like a diary every day. If you want to do it, just write your medication and write the result of your peak expiratory flow rate. So if the result, for example, let's say it's almost 90% comparing from your baseline, that's mean you are a green zone, you can write it down. And you can write at the same time what medication you are using. So because you are getting this result secondary to this medication that you are using. So we're going to continue doing the same medication because the results are satisfactory. But if the peak expiratory flow result shows that you are in yellow zone, you have to write it down, and you have to write down whatever you did causes you this sign and symptoms. For example, you do your peak expiratory flow result, and the result falls in the yellow zone. That's mean you have sign and symptoms. You have to look at yourself. What did you do, or what did you touch? Or, for example, if there is a dust, you have to say that I have to be away from the dust to prevent any future similarities. If you are in red zone, you have to write down the result, and you have to tell what was the cause, for example, causing you to have this severe obstruction in your airway. Thank you, everybody. I hope this lesson was very helpful for you, and have a safe life.